All right, let's talk about ways that we can manage patients who are in the acute stage of healing. So remember, this stage of healing is basically the tissue's response is pain and inflammation. That's what's going on in the acute stage. We can wrestle with, well, how long does that last? Is it 0 to 4 weeks? Is it 4 to 6 days? Is it 2 weeks? It doesn't really matter because what I'm saying is, in the acute phase, if somebody's in the acute phase of healing, the thing that we, clinicians, need to be concerned with is pain and inflammation. And so during this time, there's going to be a lot of stuff that happens histologically. And so generally in that first 48 hours, there's going to be a clot formation occurs, exudation of cells and solute from vessels occur, and neutralization of irritants. Chemically speaking, that's all vascular stuff. Clots form, exudation of cells and solutes from vessels occurs, neutralization of irritants. From a chemical standpoint, there's going to be a lot of phagocytic and fibroblast activity. And so if you remember what a phagocyte is basically the thing that comes into the cell and gobbles up debris. Fibroblasts are the things that come in and lay down tissue for healing. So that's kind of what's going on in this stage. Inflammation and pain are going to be the big issues, and so our job is to manage that. And again, for the purpose of this lecture, the acute phase is around 4 to 6 days. So in this phase, what do we do as clinicians? Patient education. So our big job is to educate the patient on what they can do to manage their symptoms, whether that's ice at home, whether that's resting, whether that's using a specific home exercise program that was given by the PT. We're also very much interested in protecting the injured tissue for the first 24 to 48 hours. Because remember, during that initial 48-hour period, your body's doing a lot of things to try to heal a tissue that was injured. And so this is when you come up with ideas like RICE or PRICE. So protect, rest, ice, compression, and elevation. That's the PRICE. The old model used to be just rest, ice, compression, and elevation, which is the RICE. But basically, we are trying to prevent the adverse effects of immobility here. Specifically for the tissues, we're trying to limit adhesion formation. We're trying to decrease pain by lowering the complexity and the intensity of movement that the patient's doing. We're trying to do passive range of motion and true passive range of motion, in which the patient isn't guarding. So if you're pushing somebody through range of motion and because of pain they're having reflexive guarding, we need to stop, educate the patient, try to get them to relax, and make the passive range of motion truly passive range of motion. We also want to work on general movements of the joints that are not involved. So like, for example, you're going to see patients who get a shoulder surgery. The doctor's going to ask them to be out of the sling occasionally if they're at rest, to move their elbow, move their wrist and their hand around. Specifically, if they don't have any involvement of muscles that affect the elbow, they'll ask them to move it around, move their wrist around, and things like that. And the general idea is keep these things moving so that swelling and things like that don't pull further down, right? Gravity has this effect of wanting to pull fluid down. It's the same reason why if somebody has a hip or a knee issue, you might have them do ankle pumps, or you might have them, if it's a hip issue, move the knee, and if it's a knee issue, move the hip. It's all an effort to try to keep things moving, not let them be stagnant. Basically, how do you know if a patient has done too much in this phase? Two things. Increased pain, right, that's not proportional to what they did, or increased inflammation. So they come in the next visit and the joint that you worked on is ballooned out. It's just super swollen. That means they did too much. Or if they come back in and the next time that you see them, their pain is significantly higher. 1 or 2 pain level increase, not that big of a deal. Several levels, significant, right? Contraindications during the acute phase is no stretching, right? We don't want to push past physiological range of motion because you can tear something or re-injure the tissue more, and no strengthening during this phase. We're not going to apply resistance during the acute phase. Now, are there exceptions to this? Definitely. Are we going to talk about those in the weeks to come? Yes. Are they going to confuse you as students? Yes. Well, we'll work through that. So again, during this phase, very, very important, passive range of motion. Stretching is generally contraindicated. We're going to do grade 1 and grade 2 joint mobilizations. Now these are the oscillatory, not the sustained. We're going to work on muscle setting. So this, depending on the patient and the surgery and what injury they have, isometric exercises might be appropriate in here. You're going to generally perform them in a position of rest. So generally speaking, like if you're doing a quad set, the leg's going to be straight in extension, minimize the motion the joint has to go through, if any. Because remember, with isometrics, there's not really movement of the joint, there's just contraction of the muscle. We're going to also do other things like massage, if needed, edema massage specifically to help move fluid out, help to kind of get inflammation out of the area, and then interventions to any associated area. So, meaning that we might use ice or pulsed ultrasound or game ready or other therapeutic modalities that are going to help with the healing process. For the subacute patient, remember, this is anything lasting from 10 to 17 days or 14 to 21 days after the onset of injury. It can also last all the way up to 6 weeks. This is generally the phase where inflammation is decreasing. That's from a vascular standpoint. Clots are also dissolving, and there's more repair that's beginning to happen in this phase. Remember, this is also sometimes referred to as the proliferation phase, and that's because there's a synthesis and deposition of collagen during this point, and it's the type of collagen that is going to get laid down and then later remodeled by our body. So remember what type that is. Generally speaking, in this phase, the tissue is very thin. The healing tissue is going through repair, and so it's very thin, it's immature, it's susceptible to re-injury. So generally speaking, if somebody's in the subacute phase, we don't want to get crazy and aggressive in this phase because this is where you can re-injure tissue. There's also going to be proper growth and alignment during this phase that can be stimulated by us adding the appropriate load to tissue. So you might have heard me say in previous lectures when we talk about passive range of motion, think of the chart that we put up on the board. In the acute phase, passive range of motion is the most appropriate. In the subacute phase, this is when you can start adding active assisted range of motion, because active assisted range of motion helps to prepare the tissue for the load that it's going to do in the next phase. And so that's important to remember. Again, when we manage patients with subacute injuries, patient education is still the key. A lot of it is us spending time educating the patient on limiting mobility, decreasing pain, things of that nature, using the appropriate modalities at home. Our job still in this phase is to manage that pain and inflammation. Any correction of postural faults or contributing factors that might lead to a re-injury is our job to correct in this phase. We're also going to maybe begin the activation or the initiation of active exercises in this phase, specifically multiple angle submax isometric exercises, active assisted or active range of motion exercises, working on things for muscular endurance and protected weight bearing statuses. And so, during this phase, we might start doing weight shifts. We might start doing other things that kind of help to load the joint and cause some progressive weight bearing. Also during this phase, it's important that we start initiation of and progressing of stretching exercises. So again, gentle, non-end range stretches that gently stress the tissue, because remember, it's still repairing this phase. We want to do things that are going to warm up the tissue, whether this is thermal modalities like ultrasound, continuous ultrasound, or hot packs, diathermy. We want to work on inhibition techniques, so inhibiting muscles that might be tight or limiting motion. We want to work on joint mobilizations. This is where you can start doing your 2s and 3s. Stretching techniques, massage, and the use of that range of motion through exercise. We want to look for signs of inflammation and swelling. Some discomfort should occur in this phase because, again, we're stressing tissue and prep for the next phase. And so there should be some soreness, but that soreness should only last a couple of days. Too much activity in this phase, pain at rest. It's not normal for that patient. Fatigue, so the patient's generally tired. Weakness, or spasms that last longer than 24 hours. So again, you're working muscles in this phase that haven't been used in a couple weeks. And so if you think about physiologically how long it takes to lose muscle, it only takes a couple days to lose it. It takes several weeks to gain it back. Patients should experience some soreness in this phase. It's just normal. But again, educating your patient about that beforehand is very helpful so that they understand that like this is normal, it's part of the process, it'll calm down in 24 hours, continue to use ice at home, stretch as you need to, so on and so forth. So the final phase is that chronic stage. And so patients in this chronic stage, it's deemed sometimes the maturation remodeling phase, but this is generally 21 days all the way to the end. But basically, this is where you have scars that start to develop. Scars can last from anywhere from 21 to 60 days. But in that, 3-week to 3-month, 2-month window, fibroblasts are usually remodeled. You have maturation of tissue. This is improved orientation and tensile strength of collagen. There's a balance of synthesis and degradation of collagen. Remodeling of tissue can happen up to 10 weeks. This helps your body to prevent scar formation, generally speaking, and after 14 weeks, scar tissue is unresponsive to remodeling. So think about this too. If you have somebody that has hypertrophic scars or keloid scars, after 14 weeks, we really can't do much about them other than injections or medications or things like that, which is not for us to do. During the chronic phase, again, we're educating our patient. That's a recurrent theme in all phases. We're always educating. We're always talking with our patients about things. We're going to consider progression of exercises in the chronic phase, working on building strength and function. We're also going to progress stretching exercises. This is where you can take the patient towards their end range and stretch them into end range. Progression of muscle performance exercises, so we're going to use submax to max, concentric, eccentric, open kinetic chain, closed kinetic chain exercises to work on building strength. We're going to work on developing neuromuscular control through our various different implements that we have. We're going to work on progressing strength and endurance and stimulating that functional or sport-specific activity for the patient. This is also the phase when it's appropriate to return the patient to high-demand activities. So depending on what that patient did previously before their injury, we want to get them back to that, if not more. Again, with our chronic inflammation patients, remember some of the things that happen with chronic inflammation. There's obviously a weakening effect and limitation of motion, so we want to work specifically on addressing those items with them. It's also important to understand for our chronic inflammation patients, why is it happening? Is it because it's overuse? Is there some repetitive trauma that's happening or repetitive strain that's happening? Is there a re-injury of an old injury? Or is there just contractures or poor mobility that's limiting them from getting that full progression? All right, lots of different contributing factors for these patients who have that chronic inflammation. And so that can be an imbalance of muscles, right? It can be a rapid or excessive repeated eccentric demand. So they're doing some activity that their tissue is not ready for, specifically eccentric stuff. Muscle weakness, that can be an issue. Bone malalignment or weak structural supports. Changes in the intensity or demands that were previously just normal. Returning to an activity too soon after an injury. Sustained awkward postures or motions. Environmental factors, which in this case are the things that the patient brings to the table that we necessarily can't change. Age-related factors, somebody who's young and healthy is going to heal and be progressed a little bit quicker than somebody who's old and decrepit. That's just common sense. And then training errors. Did they do too much too soon? Did we progress them too much too soon? Is there an error on our part? Again, other things that you need to make sure when we're working with chronic pain patients or chronic inflammation patients, again, we're educating them about that central sensitization phenomenon. We're talking to them about ways that they can manage their symptoms at home, whether that's through meditation, relaxation exercises, whether that's talking with a pain specialist or talking with a pain psychologist, all those different things, right? Consider progression of exercises. For the chronic inflammation patient, we want to be careful that we're not progressing exercises too quickly. Generally, less is more with these patients because, remember, any stimulus that they receive is painful. We want to progress stretches. We want to progress endurance exercises with the emphasis being on developing neuromuscular control, not so much strength. So just control, proper posture, good body mechanics, things of that nature. And then if they are doing certain activities that require a high level of function or a high demand, that we make sure that we progress those appropriately. For patients that have cumulative traumas, we want to make sure that we have modalities and rest, do some biomechanical counseling, which is basically watching them do that activity. This is like an ergonomic assessment, or this might be a sport-specific program in which you're watching them do like a pitch or things of that nature. Initiation of exercises at non-stressful intensities, stave exercises, stabilization exercises, and muscle endurance activities. All right, let's pause there. When we come back, we're going to break down and specifically talk about arthritis, arthroses, and systemic issues that relate to patient care.